patient has non-hemolytic, for transfusion reactions, there is no evidence of intravascular hemolysis. There's no hemoglobinemia, hemoglobinuria, haptoglobin, low haptoglobin, elevated LDH, jaundice, etc. Blah blah blah. So now we're thinking of non-hemolytic, right? Non-hemolytic transfusion reaction. In non-hemolytic transfusion reaction so there's no evidence of hemolysis, but they have fever, they have chills, right? Within 1 to 6 hours of transfusion. And the transfusion here can be either, it may just be white blood cell transfusion. They may, because we can get that, it may just be red blood cell transfusion, it may just be packed platelets transfusion, right? So the cause, and that will be febrile, right? We call this febrile non-hemolytic transfusion reaction. They have fever and chills, like acute hemolytic transfusion reaction, but there's no hemolysis, right? So that's going to be febrile non-hemolytic transfusion reaction within 1 to 6 hours of transfusion. So white blood cells, because of these or pathogenesis, is that white blood cells in the in packed blood, white blood cells in packed blood volume, right, once they undergo lysis, right, within those stored blood, they're going to release their cytokines within the blood. White blood cells that are in packed blood volumes, right, they're going to release their they're going to undergo lysis, right, and they're going to release their cytokines within that stored blood. So when the patient gets transfused with the blood, those cytokines, right, they're going to induce what? Feverish, mostly febrile reaction, right? Things like interleukin-1, 6, TNF, right? They're going to go to the hypothalamus, change the temperature. The patient's fever will spike, temperature will spike. They're going to have chills, right? But no evidence of hemolysis here. There's no hemolysis. We're not destroying red blood cells, nothing. To prevent this from happening, if they give you febrile non-hemolytic transfusion reaction, to prevent this from happening, we can you look for answers like leukoreduction, right, or irradiation. So we can irradiate the blood or the stored blood. We can or filter it, right? What we call leukoreduction. Remove the red blood cells, the white blood cells, the leukocytes within the blood before storage to prevent this from happening. That's going to be febrile. What about if it's non-hemolytic? So and you can see so far for febrile non-hemolytic traumatic non-hemolytic transfusion reaction, where it's a no intravascular hemolysis, right? They have fever, chills, no intravascular hemolysis. There's no hypotension either, right? No hypotension. Blood pressure will be normal, right? So they are not septic, they are not in shock, etc. Okay, if there's no hemolysis, no intravascular hemolysis, but the patient now has hypotension, they're hypotensive, they tell you the blood pressure is low. Blood pressure is low, the patient is tachycardic, right? Now we're going to be thinking of there are about 3 different factors that can cause hypotension. There's no hemolysis and non-hemolytic hypotension, right, in patients with undergoing transfusion, rather. So the first thing, the timing will give you an idea. Something that is immediate, we start transfusion and then within seconds to a few minutes, the patient develop hypotension, they're in hypotensive shock. This is going to be most likely anaphylaxis, right? This is like immediate hypersensitivity reaction. There's something in the blood that they are allergic to, right? So in addition to the hypotension, like immediate hypotension within seconds to a few minutes, we're going to be seeing angioedema, right? The mucosal surface will be swollen, also laryngeal surface will be swollen, the GI mucosa will be swollen, so they may have constipation, right? Together with that, they're going to have wheezing, etc. We're going to see urticaria, subcutaneous edema, so we're going to see urticaria, wheals on their skin diffusely. They're going to have respiratory distress, right, because of laryngeal and bronchial airway obstruction. You're going to hear wheezing and auscultation, etc. And we might see these in patients with selective IgA deficiency. This anaphylaxis to transfusion may be associated with selective IgA deficiency, because in patients with selective IgA deficiency, they don't have IgA, right? It's a primary immunodeficiency where they cannot make IgA at all. So the IgA level in their blood is like 0. The immune system will see IgA as a foreign body. It's not a self-antigen, it's not a self-protein for them, it's not a self-antigen because they can't make it, right? So the immune system will see as foreign. If they've undergone transfusion in the past before, or they've been exposed to IgA in the past before, the immune system would have been sensitized, would have made antibodies against IgA. So once you start the transfusion now, this will induce what? Histamine mediated, right? Type 1 hypersensitivity reaction, right? Anaphylaxis. So we might see so this is going to be mediated by things like anti-IgE antibodies in some patients with selective IgE deficiency. To prevent this from happening, we can wash the packed red blood cell. Wash the packed red blood cell, which will remove all the IgAs, right, in the protein, in the stored blood, right, and then before we transfuse the blood. So that's how we prevent this from happening in patients with selective IgA deficiency, right. A patient has hypotension, and this occurs within 1 to 6 minutes. Such transfusion, the hypertension occurs between 1 to 6 minutes. It could be due to ARDS, it could be due to CHF, right? ARDS, CHF can also cause this. So if the cause of hypotension shortly after sepsis transfusion is ARDS, acute respiratory distress syndrome, that's going to be transfusion-associated lung injury. It's called TRALI. Transfusion-associated lung injury. So the patient, in addition to the hypotension, they're going to have pulmonary edema, right? Because there are substances in the blood that is damaging the lungs now, causing massive inflammation of the lungs. It's going to lead to increased permeability of the vessels in the lungs. There will be decreased surfactant production. Basically, this is like acute lung injury. So there will be diffuse pulmonary edema bilaterally. We're going to hear that on auscultation. They're going to be hypoxemic. This patient actually requires ventilator. That's how bad, right, the hypoxemia will be, right? You give them oxygen by mask, it won't help. Oxygen saturation will be low. We have to put them on a ventilator. They have pulmonary edema both on auscultation and X-ray. Chest X-ray will show pulmonary edema, but this patient have no evidence of CHF, right? So the heart is fine. No evidence of right heart failure. No evidence of left heart failure. And here is due to anti-leukocyte antibodies, right? So antibodies against the white blood cells. They're going to start attacking the white blood cells. There'll be increased lysis of white blood cells within the patient's blood. All those cytokines now goes to the lungs and start damaging the lungs. So that's going to be TRALI. A patient has hypotension within 1 to 6 hours plus features of CHF, right? Actually, patient with history of maybe CHF already, somebody that already has CHF, or they have a disorder where there's decreased cardiac function already, like ischemic heart disease. Patient has MI already, angina, valvular heart disease, like mitral stenosis, etc. By the time we give them transfusion, right, what happens? There will be volume overload to the heart, so they're going to undergo acute decompensation, acute decompensated heart failure. So that's what we call TACO, right? Transfusion associated volume overload, right? Volume overload. See, I can't remember what C means. Yeah, so transfusion associated volume overload in the heart, right? So the patient will have decompensated, right, CHF or heart failure. We're going to see evidence of left heart failure. There will be pulmonary edema by basilar crackles, etc. They're going to go into shock, right? They're going to be in shock, cardiogenic shock, because of low forward or cardiac output. They're going to have evidence of right heart failure, so distended jugular veins, hepatomegaly, right? So this is going to be what, yeah, and the patient will have risk factor of decreased cardiac function in their history, things like ischemic heart disease, maybe long-standing hypertension, where there's already CHF, but they are stable. Now, if you give them transfusion, too much volume return to the heart, right? Transfusion cardiac overload, right? That will lead to TACO. So within 1 to 2 hours or later. So that's going to be that. Hypotension within few minutes, but every other thing looks normal, right? Hypotension within few minutes, but every other thing looks normal. You don't have angioedema, no urticaria. You rule out TRALI, lungs clear. You rule out CHF, no TACO, right? This is going to be like a transient, right? Primary hypotension reaction. This is going to be a transient primary hypotension reaction. They have hypotension and then got better spontaneously, right? This is like a diagnosis of exclusion. They are hypotensive within minutes of certain transfusion and then go better spontaneously. If a patient, we can see this in patient on ACE inhibitors. If a patient is on ACE inhibitor, captopril, enalapril, etc., these drugs will block ACE. In the stored blood, the lysed WBCs, right? They're going to release bradykinin into the blood. So by the time you transfuse that blood, the bradykinin in that blood will be very, very high, right? And since we've already inhibited the enzyme that normally breaks down bradykinin, it's going to what? Bradykinin will stimulate its own receptors, lead to widespread peripheral vasodilation. So that will lead to a transient hypotension, but bradykinin will still eventually be metabolized, right? Though slowly, it's going to eventually get metabolized, and this is going to be a transient event. They're hypotensive, but you rule out every other thing. It's not, they don't have TRALI, you don't have TACO, you don't have anaphylaxis, full anaphylactic reaction, just bradykinin mediated, right? Hypotension, maybe you might see angioedema, but there'll be no pruritus and those kind of things. Here we're going to see pruritus, right, of the skin, itching of the skin, histamine mediated. So you're going to be thinking, right, transient primary hypotension reaction, right, in patient on ACE inhibitors. If they have it within minutes or hours or even days, and now with evidence of infection, they're in septic shock or sepsis, fever, chills, evidence of septic shock, peripheral vasodilation, there's warm extremities, their skin is warm and dry, they have blood culture may even come back positive, right? Temperature is high, WBC is elevated, right? They maybe, if it's gram-negative sepsis, they may have DIC, right? So now we're thinking bacterial sepsis. This is not common anymore, right? But it can occur. Bacteria can contaminate the blood, stored blood products, and then after transfusion, they're going to go into septic shock. So this patient will require antibiotics, IV fluids for stabilization, right? And then you stop the transfusion, send it back to the lab to confirm the most likely cause. So these are going to be transfusion reactions, right? So divide them into hemolytic versus non-hemolytic. If it's hemolytic, go straight. Acute versus delayed based on time and severity. Acute, we have to quickly stop, so that's important to diagnose as early as possible. If it's non-hemolytic, if it's just chills, fevers, non-hemolytic and no hypotension, we're thinking febrile, non-hemolytic transfusion reaction. If they're hypotensive now, depending on the time and other symptoms, you can determine if because of anaphylaxis, if it's immediate, right? If within 1 to 6 hours, either TRALI or TACO. If they have evidence of heart failure, it's going to be TACO. If they have evidence of pulmonary edema or lung injury, it's going to be TRALI. If the patient has transient hypotension, got better spontaneously, right? Primary hypotension reaction, right? And then if we see evidence of sepsis, then it's going to be bacterial sepsis or infection. So that is going to be transfusion reactions. Guys, good, excellent.